This is episode 80 of the Psychcast by MDedge, where we bring you interviews with leaders in the field, masterclass lectures, and relevant inspiration straight to your ears, with new episodes dropping every Wednesday. I'm the voice of MDedge Podcasts, Nick Andrews. Coming up later in the interview portion of our show, we have a great guest for you. We're publishing this episode smack dab in the middle of hurricane season in the Atlantic Basin and in the wake of Hurricane Dorian. And that's exactly what this episode is all about. Editor-in-Chief of MDedge Psychiatry, Dr. Lorenzo Norris, welcomes Dr. Judith R. Milner to talk about the mental health response to natural disasters, and specifically, hurricanes. The interview can be found at about minute 5 or 6 if you want to skip ahead, and there are timestamps of the exact time of the interview available in the show notes. And of course, following our interview, as always, we have a new installment of Dr. RK, who wants to talk about memories. Remember, this episode comes with robust show notes, courtesy of Dr. Jacqueline Posada. In the notes, you can find an outline of the interview, links to material referenced in the conversation, as well as biographical information about our guest. Before we get going, a quick word about what's coming up on the Psychcast. This fall, we're going to have episodes about postpartum psychosis, neuroimaging and forensic psychiatry, and we're going back to the MDedge Psychiatry board member, Dr. Dinah Miller, to talk about involuntary treatment. Also, Dr. Norris and I will be at the 2019 annual meeting for the Group for the Advancement of Psychiatry, known as GAP, in White Plains, New York. That's coming up later this fall. If you'll be at the GAP meeting, come say hi to us. We're going to be chatting with thought leaders once again this year, so if you have any topic ideas or requests for us at GAP 2019, please email us at podcast@mdedge.com, and we'll be sure to work those in to our conversations. This is the 80th edition of the Psychcast, which is just amazing. We thank those of you who have joined us for all or any of the 80 installments of the show. If you've only recently discovered us, or if maybe you don't listen every week, we're going to be publishing an In Case You Missed It series of interviews and episodes that are at least a year old. Our first edition will be later this month and will feature Dr. Henry Nasrallah on schizophrenia. So look for that coming up later in September. Okay, it's time now for our new segment, This Week in Psychiatry. If you want to learn more about this piece, you can find a link to the web article and a link to the downloadable PDF in the show notes wherever notes are found in your app. Our piece this week is titled Miracle Cures in Psychiatry by Dr. Catherine Epstein and Dr. Helen M. Farrell. Doctors Epstein and Farrell write that there has been growing excitement about new treatments that might be, quote, miracle cures for patients with mental illness, particularly for individuals with treatment-resistant depression. The authors wonder how psychiatrists ought to evaluate the usefulness of these new treatments and how should clinicians talk to patients about these so-called miracle cures. First, they explore the duty to patients. The authors write that psychiatrists have a duty to patients to evaluate the safety and efficacy of new treatments that are available, whether they are approved by the FDA or not. Furthermore, psychiatrists should protect patients from the adverse consequences of relatively untested drugs. As an example, Dr. Epstein and Dr. Farrell write that ketamine and hallucinogens both produce dissociative effects and may carry high risks for patients who have a predisposition to psychosis, and note that psychiatrists should protect patients from false hopes that might lead them to abandon their current treatment regimens. In the discussion portion of the article, the authors suggest 5 categories that can help quickly assess a new treatment. 1. Evidence. Psychiatric research may be even more susceptible to placebo effect than other medical research, particularly for illness with subjective symptoms, such as depression. 12 double-blinded placebo-controlled studies, such as the 4-ketamine trial conducted by Sang et al., 13 are the gold standard for separating a substance's actual biologic effect from a placebo effect. 2. Mechanism. If a new compound appears to have a beneficial effect on mental health, it is important to consider the potential mechanism underlying this effect to determine if it is biologically plausible. A compound that is claimed to be a panacea for every single symptom of every mental illness should be heavily scrutinized. 3. Reinforcement. Psychiatric medications that are acutely reinforcing have significant potential for abuse. Antidepressants and mood stabilizers are not acutely rewarding. They don't make patients feel good right away. Medications such as stimulants and opioids do, and must be used with extreme care because of their abuse potential. 4. No single solutions. A mental disorder is unlikely to have a single solution. Rather than regarding a new treatment as capable of rapidly alleviating every symptom of a patient's illness, it should be reviewed as a tool that can be helpful when used in combination with other treatments and lifestyle practices. 5. Context. For a medication to obtain approval to treat a specific indication, the FDA usually requires 2 trials that demonstrate efficacy. Off-label use of generic medications such as ketamine may have benefits, but it is unlikely that a generic drug would be put through a costly FDA approval process. Dr. Epstein and Dr. Farrell conclude by writing that when patients request these new treatments, whether they are or not approved by the FDA, it is the responsibility of the psychiatrist to educate the patients about the benefits, risks, effectiveness, and limitations of these treatments. And that concludes This Week in Psychiatry. Remember, you can find a link to the web version of the article or a downloadable PDF by clicking in the show notes. Okay, it's time to meet this week's guest for the interview segment. Dr. Judith Milner is a private practice psychiatrist in Washington State. She has been working all over the world in war-torn countries and in countries ravaged by natural disasters. She has been on the ground, training local responders how to recognize and treat those with PTSD in adults and in children. Okay, let's get to the interview. Please welcome the host and editor-in-chief of MDedge Psychiatry, Dr. Lorenzo Norris.
I've been involved in doing trauma work both nationally and internationally, and I've traveled with several groups, the International Center for Psychosocial Trauma, Step Up Rwanda Women, Global First Responders, and I've been to various areas that have been ravaged by war and natural disaster, and we've attempted to train those people who are working with the survivors of the disasters how to recognize and treat PTSD in both children and adults.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MDedge Psychiatry. I want to welcome you to today's Psychcast, where we are privileged to have Dr. Milner joining us. And Dr. Milner is going to talk to us about a very important topic, particularly the mental health needs of hurricane survivors, and how can we as mental health professionals help. Many of the viewers and our listeners in the audience may have already been experiencing the direct effects of Hurricane Dorian, and those and many other listeners have dealt with, if you will, natural disasters. So I really do feel as though this Psychcast is important, and I think it's really essential that we as mental health providers understand the best ways in which we can be of assistance to our community as well as to our patients. So, Dr. Milner, I want to welcome you to today's Psychcast.
Thank you, Dr. Norris.
Now, Dr. Milner, a few things. When we think about, if you will, mental health providers' response or the mental health needs of patients dealing, in this particular case, with Hurricane Dorian, can you tell us, if you will, can you elaborate on, if you will, how should we actually approach or have a response to natural disasters?
Well, I think that those of us in the helping professions naturally feel a sadness and a compassion for people who are going through these devastating situations, and many of us want to reach out and do something to help. And of course, we can do things on a local level. We can volunteer at our local churches or shelters that are collecting goods to send to people, and we can work for climate change on a local level, and we can work to help people who may be refugees, climate refugees, to our areas. But many people want to go to the site of the disaster and help there. They want to provide immediate assistance. And so what's so important about this aspect is that the worst thing you can do is just go and show up on the site and say you're going to do whatever needs to be done, because there are always some groups on the ground when you get there, but you need to be with a group before you go. You need to be going in an organized fashion and not contribute to the chaos that already exists there. sometimes when people just show up there, it increases the liability of the groups that are already there, because some people who show up there become secondarily traumatized by what they're witnessing, and then they have to be cared for as well. So it also depends on when you go. If you go now, say to Hurricane Dorian, this would be the devastation phase. There are 3 phases of recovery from a hurricane or a natural disaster. And so in the first stage, you have complete devastation. In the second stage, you have a normalization of the disaster response. And then the third stage, you have acceptance of the new normal. But the stage we're currently in with Hurricane Dorian is the devastation.
Yeah, so Dr. Milner, thank you for actually just elaborating on those, if you will, those pre-phases of, if you will, or stages of a disaster response. The devastation phase, if you will, the normalization of the disaster response, as well as, if you will, the acceptance of the new normal. And again, just to reiterate a point that you said, because I Dr. Craig Katz, a colleague of mine, or actually a mentor and, if you will, attending, who taught me at Mount Sinai Department of Psychiatry, would talk about this idea of people coming in too early and not being able to really help. Everyone kind of maybe having that hero reflex, for lack of a better word, or being, as you said, compassionate, but actually adding to the problem because they're not coming in an organized fashion and working with a group. So at this point in time, we are at that devastation phase in Hurricane Dorian. What would be things that, in terms of, for a mental health professional not to actually go there, but what do they need to understand what is actually going on in this devastation phase that other organizations are doing right now?
Well, what's going on now is that there have been, there are at least 50 people dead and probably more than that, and thousands of people are missing. 2,500 people have been reported missing. This is in the Bahamas because the storm also affected our East Coast. And so 76,000 people have been impacted, and probably 13,000 or more homes are destroyed or severely damaged. So, and survivors are still being discovered now, this far out, who haven't had food or water since the storm. So at this point, the organizations that are there, like AmeriCares and the Red Cross, are just trying to get people into shelters, organize the shelters, make sure that people have food and water and their necessary medications. Volunteer medical groups are providing medical care as they can for people who have medical issues. And in terms of psychiatric help or mental health help, at this point, what's really being utilized is psychological first aid, which really means that the people and by the way, people can obtain training in psychological first aid at the Red Cross. But what psychological first aid entails is it's basically helping the people. Often you'd be administering this in a shelter, and you help the people feel comfortable. You ask them if they want food or water. You help them connect with family and friends and other loved ones. You may help them fill out forms if they need to apply for some sort of financial aid just to have money to live on or to begin the process of repairing their homes. And you try to establish a schedule so that they're in the shelter, they're eating at regular times, there's certain routines because there's some assurance in the routines. And with the children, you may be doing, activities like drawing pictures, having the children draw pictures, having the children play games. But you never want to force someone to talk about their experiences. This has been tried in the past, critical incident debriefing, and sometimes that can be re-traumatizing to an individual rather than healing or helpful.
So,
but if they want to talk, you definitely want to be there to listen.
When I think about this phase, just as you've described it, we really need to be attuned to the basic needs of our patients. I mean, shelter, safety, food, providing basic support. And many of these things, depending on where you practice, whether you are a hospitalist, community psychiatrist, private practice psychiatrist, this may or may not be part and parcel of what you do in terms of just attending to those basic human needs, as well as maybe if you were rolling up your sleeves and taking out your stethoscopes, if needed, if you're on boots on the ground. But as you described it, our main thing that's my takeaway point is that we need to be focused on the basic human needs, and of all what you said in terms of, if you will, schedule, structure, I think about just helping people establish a sense of coherence and equilibrium so that they can make sense out of this phase without any additional trauma. And that might be a little bit different than what most of us are taught to do if we're in private practice and we're probing into a chief complaint or going deeper and deeper, whereas this, we're actually trying to stabilize and basically take care of human needs, if I heard you correctly, Dr. Milner.
Yes, exactly. And just as sort of an aside, some of my colleagues who volunteered with the Red Cross after Katrina found themselves in rather remote shelters, and being the only MD there, they were asked to, prescribe meds for patients who didn't have their hypertension meds or their heart meds or other medications for medical conditions, which as psychiatrists we typically aren't prescribing meds for. So I think that somebody who wants to volunteer needs to ask questions about the situation they're going to be in and what the expectations of them are going to be. Because, some psychiatrists may or may not feel comfortable in that role. But, we may be called upon to do various things if we go during this stage of the disaster to volunteer.
Absolutely. Dr. Milner, can you tell us about the next phase of the disaster response, the normalization phase, if you will?
Okay. I just wanted to say that on this outline that I provided, there are a number of groups that people can contact if they're interested in going at this phase or at a later stage of the recovery. And the New York Times just published an article, I think, on the 3rd, and they described some of the organizations, also that are local Bahamian organizations that people might wish to contact. And also the Charity Navigator does provide you with a listing of various organizations through which you can work. But so the second stage is the normalization of the disaster response. And this during the first stage, everybody's going to experience stress and sadness and loss, possibly shock after the disaster. And for some people, this may last days to months, but usually the normalization of the disaster response begins within days, and this does last months. And so during the normalization stage, you have both the honeymoon response, so the honeymoon phase, and the disillusionment phase. And the honeymoon phase is when after you've gotten over just the shock of the disaster and what you've experienced, you feel grateful for having survived. And you begin to have some hope for the future. Maybe you'll be able to relocate. Maybe you'll be able to rebuild. Maybe you'll be able to go back. Maybe your life will be the same as it was again. But then following this, you experience the disillusionment phase. And this is when the grueling reality of what recovery means for you actually hits home. And so during this time, you realize it's maybe difficult to get the funds that you need to survive. It's not it's not as easy to evacuate or leave as you might have thought. There's no place for you to go locally. You don't know, your future is uncertain. You don't know where you're going to go when the shelter closes. And it's during this stage that various psychiatric conditions may develop.
Yes, please, Dr. Milner, if you could tell us what are the common conditions that we might start to see during the normalization phase.
Okay, well, initially, as I said, most people are going to have symptoms of stress. And people who've been through a life-threatening disaster, most of them will experience some symptoms of an acute stress disorder, if not the entire disorder. And this lasts up to a month. And this has the same symptoms of a post-traumatic stress disorder. It's just that the duration is longer than the PTSD. It's shorter than the PTSD. So you do have you've experienced a life-threatening event. You have symptoms of re-experiencing avoidance, hyperarousal, and a negative emotional state. So, and this manifests differently in adults, children, and adolescents. So you may have hypervigilance, insomnia, difficulty having warm and loving relationships with others. You may be having nightmares, flashbacks, dissociation. You may feel as though you're back in the situation and be paralyzed emotionally in that state of dissociation. There may be various triggers. For example, many of the places that I have traveled to with the International Center for Psychosocial Trauma, the children are very triggered by the sound of water. The rain scares them. The sound of the toilet flushing serves as a trigger. And so this lasts from 3 days to a month, the acute stress disorder. The post-traumatic stress disorder has the same triad of symptoms, the re-experiencing avoidance and hyperarousal, and also a component of the negative emotional state. But that can last years after a disaster of this sort. And actually a study just came out that showed that people who are living in weather-damaged homes tend to have higher incidences tend to have a higher incidence of both anxiety and depression. And when one is experiencing post-traumatic stress disorder, it's common that they will also experience comorbid disorders, such as depression, dysthymia. In children, they may experience learning problems, ADHD, conduct disorders. Substance use disorders are often accompanying the PTSD because people are attempting to self-medicate. And unfortunately, once you get out of the U.S. or even probably the more coastal areas of the U.S., it is more difficult to get psychiatric help. So people have fewer recourses.
And I could absolutely imagine that, Dr. Milner, in terms of once you get outside of certain population areas, the difficulty in receiving psychiatric help. In that normalization phase, like thinking about this honeymoon phase, or if you will, a sense of hope and acceptance, then disillusionment and grief. Now, let's take just asking some questions. It's based off of your experience in working in these, if you will, areas. Is there anything that you particularly look for in terms of patients who are not going to successfully navigate either out of, let's say, grief phase and return to normal versus grief and some type of complicated bereavement, if you will, for lack of a better word, or, if you will, an acute psychiatric condition such as acute stress disorder?
Yes. Well, the more stressors someone has experienced in their life, the more likely they are to experience PTSD. Okay. And so if somebody's already impacted by stress, if they've if they've grown up in poverty, if they've grown up in a situation where there was domestic violence, or there was a loss of one parent, or perhaps they had childhood illness, or perhaps one of the parents had childhood illness, or maybe they experienced bullying at school, or if they have been the victim of abuse, physical, sexual, emotional abuse at the hands of another, or if they've witnessed domestic violence, or if they've experienced other natural disasters, all these things predispose an individual to developing one of these disorders. And there's also a genetic component to anxiety and depression. So if there's already a family history of anxiety and depression, that means that genetically they may also be predisposed.
Okay. So we know that from what I'm hearing right now, more stress in and of itself, particularly if you have a predisposition to a psychiatric condition, or you have one in and of itself, can certainly, if you will, precipitate, the development of acute stress disorder or post-traumatic stress disorder. In addition to that, I was just kind of thinking about this. We're mental health professionals. We're going in. We have to be mindful if we're going in during the destabilization phase of a disaster response to make sure that we're going in with an organization. And it strikes me that if we don't get that, if you will, that destabilization in the devastation phase of the response correct, that's just going to be an added stressor that could interfere with the, if you will, the normalization response to the disaster. So I definitely think about that. And I was also reflecting on what you said about actually being able to get to psychiatric resources, whether it is medications or therapists or a psychiatric provider in the midst of this, because I would imagine that that would also be a factor in people either, one, developing acute stress disorder or post-traumatic stress disorder, or those with those conditions and other comorbid, if you will, psychiatric conditions not getting or those with other comorbid psychiatric conditions really kind of going in a worse direction. I was wondering if you could talk a little bit about, in that normalization phase, a bit about this concept of training the trainer, because one thing that I remember others have talked about, frequently everyone will be very empowered or enthusiastic during the acute stage of a disaster, which can go on for the first week or 2 weeks to 2 or 3 months. But really, when you think about it, who's going to stay? Who's going to be there 6 months to a year after? How are you going to support the community then? So I was wondering if you could talk a little bit about the training the trainers model.
Well, yes, that's it. It works very well as a way of providing help to people, because often, even post-disaster, you'll find that many of the doctors have left. Some stay, but also many of the therapists and the psychiatrists have left. So we've trained a lot of different people. We've trained a lot of teachers in the International Center for Psychosocial Trauma, but in Rwanda, after the genocide, which was, of course, a human-made disaster, there were no counselors, and here you had this nation of 1 million traumatized individuals, and we were training administrators and anybody who wanted to be trained that was at Kigali Health Institute in these techniques. And so what you actually do is you train the trainers how to recognize the conditions that I just mentioned: acute stress disorder, PTSD, depression, and persistent complex bereavement disorder. You teach them how to recognize the conditions, and then you teach them techniques for helping them help the individuals that are suffering with these. And, dialectical behavioral therapy and cognitive behavioral therapy are manualized forms of therapy, and you really need to be trained in those, as well as trauma-focused cognitive behavioral therapy. But there is training available, and I have mentioned some of the places where it might be available in the handout. But there are other things that you can teach people who may not have a medical or a mental health background. You can teach relaxation exercises. You can teach yoga breathing. There there are 2 Dr. Browns in New York that have actually showed that yoga breathing was as helpful as medication in groups of refugees who were suffering from PTSD. You can teach visualization techniques. EMDR is another technique that you need to be trained in, but still you can be trained in that. And there are various expressive therapies that are helpful in helping people work through their trauma.
With the training model, Dr. Milner, is that something, how can, if you will, mental health professionals, is that something that organizations would teach you? Is that something where they can go and learn about that? How would you learn how to actually implement that model?
The International Center for Psychosocial Trauma gives a yearly trauma course where you can learn these techniques. There are some excellent material. You can learn about getting all kinds of training if you look at the American Academy of Child and Adolescent Psychiatry Practice Parameter on Disaster Preparedness. It is very thorough and it has multiple references. But you can also attend the Committee on Psychiatric Dimensions of Disaster annual course at the APA. And then there are various other organizations that provide training. One who has an interest could contact the National Center for PTSD, the National Child Traumatic Stress Network, and the Center for the Study of Traumatic Stress, as well as the International Society for Trauma Stress Studies. And I think that there are, and also the Carter Center provides training. But specifically, I would start with the International Center for Psychosocial Trauma to receive training for training the trainers. Those are some of the places where people can receive training. Oh, and there's also a disaster psychiatry outreach group, and one can contact them for further resources. But I really think that also reading this AACAP practice parameter on disaster preparedness, there are so many references in there where one can obtain various information and training.
Okay, well, superb. I think that is exceedingly useful information, and we'll make a point of, if the regular listeners to the Psychcast know that we produce show notes, and we'll have all of the information that Dr. Milner is talking about in the show notes. Now, in terms of the disaster response, Dr. Milner, I wanted to talk a little bit or hear a bit more about that acceptance of the new normal, because I think that for a number of mental health professionals, that may not that it may be, it most certainly would be an area where they are absolutely likely to encounter, if you will, patients or those recovering from, if you will, the effects of a natural disaster.
So during this stage, as I said, the PTSD can go on for years, and most people will recover, and the estimates of the people who end up having persistent PTSD vary, and it depends upon the study you look at. They may vary from 25 to 40%, which 40% is pretty high, and probably all people will continue to have some symptoms but not meet the full criteria. So during this stage, ongoing help is needed, and so at that point, it's helpful to be able to have some sort of ongoing therapy, and often this therapy, because as we mentioned earlier, there aren't always so many psychiatric resources available. So this ongoing therapy can often be delivered in the form of group therapy, and so this is part of where training the trainers comes in, because one of the techniques that is taught to trainers is how do you use a group to help people, talk about their trauma and learn healthier coping techniques and heal. So group therapy may be one way to deliver ongoing help, but from the perspective of the psychiatrist or the mental health professional who's volunteering to help, what I think is really important is if you go someplace after a disaster and you train the trainers, it's important that you keep in touch with the trainers, that you don't just go and train the trainers and then leave. It's important to follow up and see how things are going and see how they're utilizing the training and see if they need, refresher training and see, how their clients are doing with the techniques that you have taught them. And so I think that's a really important part of the acceptance of the new normal. But also I think that the people that are more able to accept the new normal are the people that were probably less stressed prior to the disaster. So it's easier to accept the new normal if they have the economic resources to go on, if they have help in rebuilding, if they have some sort of a reasonable alternative housing facility that they can live in the meantime. And so I think that then it's easier for people. So the more that we as the volunteers can also help them connect with resources that can be helpful to them, that also is going to help their psychological stability in the long run. And there are various things that people do to enhance their own resiliency. And it is amazing to see how resilient people are when you really travel to some of these areas and see how people recover after disasters. And so part of training the trainers, part of what you train the trainers to do is you train the trainers to help the people that they're working with develop their own resilience and help their own resilience grow. I was just amazed at some of the places where we've been, how the people we were training had experienced terrible losses themselves, but actually by their volunteering to help others, it was helping them cope psychologically with their own losses. So volunteering and service to others is one way of enhancing one's own resilience. Anyone who volunteers needs to be aware of compassion fatigue also.
Okay. Well, Dr. Milner, I really feel as though you have done a superb job of really helping us navigate, if you will, those three phases of a disaster response, the devastation phase, the normalization phase, as well as the acceptance of the new normal. You've given us really some really key things to think about in each one of those phases, how we as mental health professionals can structure our intervention to meet the needs of our patients and our communities. And you've really helped us start to think about the different forms of training as well as different resources in the form of organizations as well as formal training that we can utilize to prepare ourselves in terms of going in, if we so choose to, in terms of working with those that are affected by natural disasters. So, Dr. Milner, I want to thank you so very much for coming on today's Psychcast. Do you have any final words for the audience?
Well, in terms of compassion fatigue, I just wanted to refer people to the Compassion Fatigue Awareness Project, because some people who volunteer can volunteer so much that they exhaust themselves and their experience secondary traumatization themselves. So I guess those would be my final words, that it's wonderful to volunteer. And I just am so happy that I've had every opportunity I have to go and help other people recover from these disasters. But I also think it's really important to take care of ourselves so we can continue doing that sort of work. And Thank you, Dr. Norris, so much. I really appreciate you asking me to do this podcast. It's been a pleasure.
Well, thank you so very much, Dr. Milner.
And that concludes this week's interview. Remember, there are robust show notes available wherever notes are found in your app. The notes include a full outline of the conversation as well as relevant links discussed. We'll be right back with a talk on memories. Welcome back to the Psychcast by MDedge. I'm Nick Andrews. It's time now for Dr. Renee Kohanski.
Thank you, Nick, for the introduction as always. As I say those very words, I think how appropriately it ties to this program. This idea of remembrance, rituals, and dates. The construct of time itself is a wholly man-made concept. The universe is infinite, and in the scheme of infinity, what is our lifetime? One can zoom in and zoom out and find meaning in the funniest of places. For example, remember the movie Men in Black and how it ends with that collar around Orion's neck? Orion was a cat. And that held a universe within a universe. Kind of silly, but it was actually very, very profound. Now, where is she going, you might be asking yourselves? Well, time. What marks this artificial construct of time? We do. We choose what is important and meaningful. There are countries that don't identify birth dates. Not only do we identify them, we celebrate them. And we identify dates of deaths. There is now a whole generation of children that are 20 years old, and they've passed through 9/11, but they don't actually remember it. Can you imagine? Much like those who lived through Pearl Harbor and the assassination of President Kennedy, people couldn't imagine anyone who had not actually lived during that time and experienced it. And this year, we remember those who perished on that tragic Tuesday and honor those who bravely acted in both small and big ways. We remember ourselves on that day, just like those other monumental days, because there are those times that absolutely change the course of life as we know it, whether it be on an individual, national, and sometimes worldwide level. And memory is crucial. That deeply embedded amygdala hippocampal structure so near and dear to our temporal lobes. Such a shame there isn't a more direct circuit to our later evolutionary neocortex, our two brains, sometimes destined never to meet. Our collective amnestic brains, because even now we are beginning to forget and rewrite. We say we will never forget, but sadly we often forget. And what we forget, we are destined to repeat and replay, an infinite repetition compulsion. Or, if you will, sometimes something utterly, completely unique will emerge, unforeseen, unpredicted, what my favorite author, Nassim Nicholas Taleb, would call a black swan, and what he would say has anti-fragile properties. But for now, I use the poor little tools that I have. So, thank you for the introduction, Nick. I'm Dr. Renee Kohanski for the MDedge Psychcast.
And thank you, Dr. RK. Okay, that concludes the 80th edition of the Psychcast by MDedge. Let's conclude this week, as we always do, by giving credit to the entire Psychcast team. The Psychcast is hosted by MDedge Editor-in-Chief, Dr. Lorenzo Norris. Our guest this week was Dr. Judith Milner. The Dr. RK portion of the show was written, produced, and recorded by Dr. Renee Kohanski. The show notes are authored by Dr. Jacqueline Posada. Psychcast audio and content producers are Gina Henderson and Jeff Bauer. All MDedge podcasts are produced by our editor-in-chief, Mary Jo Dales. Executive editors Denise Fulton and Kathy Scarbeck. MDedge multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I am your audio engineer, audio editor, and the voice of MDedge podcasts, Nick Andrews. We'll see you next time on the Psychcast by MDedge.